Imagine you're standing at the microscope, maybe just finished your fellowship, and a biopsy slides into view. It's a soft tissue mass, and right away, something striking jumps out. It's just brimming with this abundant, almost jelly-like substance, what we pathologists know as a myxoid stroma.
Mm.
Now, these myxoid tumors are, well, they're a truly fascinating group, but they can be incredibly challenging. They can range from something totally benign, straightforward, like a ganglion cyst, easy to manage,
Yeah.
all the way to aggressive, really life-threatening sarcomas. And the sheer overlap, I mean, the way they look clinically, histologically, it can make them, frankly, a diagnostic minefield, even for experienced folks. So for you, maybe a new surgical pathologist transitioning from BST fellowship to independent sign-out, getting a handle on these nuances isn't just helpful, it's absolutely critical for confident practice for your patients. Our mission in this deep dive, we want to unpack the most important distinguishing features. We'll highlight those diagnostic pitfalls that can, trip anyone up, and equip you with the crucial ancillary tools you need to nail down a confident diagnosis in this tricky area. Think of it like maybe a tappy board review, but maybe even more intense, more in depth, specifically designed to really get you ready for that independent practice. We're going to take a really deep dive into comprehensive pathology sources here, looking at the microscopic morphology, the IHC profiles, and the really crucial molecular genetics that can quite literally make or break a diagnosis. Our goal is to pull out those nuggets of knowledge, those single decisive features that help you tell one myxoid tumor from another, turning what could be potential diagnostic headaches into confident, accurate signouts. Okay, so let's unpack this a bit. Myxoid tumors, like our sources keep saying, they're a remarkably varied bunch, aren't they? United only by that characteristic abundant extracellular matrix, that jelly stuff. But well, that's pretty much where the simplicity ends, right? What makes this group so diagnostically challenging, and why is it so incredibly important to get the diagnosis spot on?
That's an excellent way to frame it. And it's true. What's really fascinating and also challenging is that despite sharing that myxoid matrix, these tumors behave so differently. We're talking about a whole spectrum from, self-limited, totally benign lesions needing maybe just a simple snip, all the way to tumors with a really high chance of coming back locally, and then, of course, aggressive sarcomas that can spread and be life-threatening. So the critical nature of getting it right, it comes directly from what it means for the patient. Are we talking simple excision? Or do we need more aggressive surgery, maybe radiation, maybe even chemo? And as our sources really hammer home, that huge clinical and histologic overlap absolutely demands a systematic approach, a really meticulous one. You, the pathologist signing these out, you just can't afford to skim the surface here.
Yeah, that huge difference in behavior is exactly why we need to be so sharp. So given the significant overlap you've laid out,
Yeah.
what are the initial things, those key features you absolutely have to pay attention to right off the bat when you encounter one of these myxoid soft tissue tumors? What's on that immediate mental checklist?
Okay, good question. Our sources lay out several vital features, almost like a checklist for that first look down the scope. First, always consider the depth of the lesion. This seems simple, but it's key. Is it dermal? Just in the skin? Is it subcutaneous, sitting right under the skin? Or is it deep? Maybe subfascial, below that tough fascial layer, maybe sneaking between muscles. This detail alone can really narrow down your differential diagnosis quite a bit. Certain tumors just love specific depths.
Okay, depth first. Makes sense. What's next?
Second, you got to carefully assess the extent of the myxoid stroma. Is it everywhere? Just tons of it, diffuse, making the whole thing look gelatinous? Or is the myxoid change more limited, maybe just focal patches here and there, mixed with other stuff? Some tumors are uniformly myxoid, almost pure jelly. Others just have focal myxoid change within, say, a more fibrous or cellular tumor. It's a subtle clue, but important.
Right, how much jelly is actually there? Got it.
Third, and this is a big one, a major red flag if you see it, carefully evaluate the presence or absence of nuclear pleomorphism. This is absolutely critical for figuring out malignant potential. For instance, a classic intramuscular myxoma, or even the cellular variant, is known for having a striking lack of nuclear atypia. The nuclei look bland, uniform. That's a sharp contrast to something like myxofibrosarcoma, which even in its low-grade forms will show scattered pleomorphic cells. Nuclei that are bigger, darker, more varied in shape. Spotting those abnormal nuclei is paramount. They're often the first hint you're dealing with a sarcoma.
Okay, pleomorphism, look for those ugly nuclei. That's a huge point. And the last one.
And finally, something that's often, I think, underappreciated but can be super characteristic, the distinctive vasculature. You really need to train your eye to see the vessel patterns. Are you seeing delicate, thin-walled branching capillaries, maybe looking like chicken wire or sometimes called crow's feet, or are they forming more prominent arcades of vessels? Like loops, these specific vascular patterns are often really, really helpful, sometimes almost pathognomonic for certain myxoid tumor types. They're like hidden clues within the stroma.
Yeah, those vessel patterns can be tricky to spot initially, but incredibly high yield once you get your eye in. That brings up a really critical point about sampling, doesn't it? Our sources really stress this. Why is it so vital to adequately sample these myxoid tumors, especially, when you're starting out, signing out independently? What's the risk if you don't get enough tissue or the right tissue?
Ah, that's a crucial question for independent practice. Absolutely vital. The reason extensive sampling is so critical is that these key morphologic clues we just talked about, the pleomorphism, the specific vessels, even just how much myxoid change there is, often aren't spread evenly throughout the tumor. It's easy, really easy, to miss a small focus of high-grade atypia that screams sarcoma, or that one area with the characteristic vessel pattern, if you don't sample widely. Imagine getting just one small core biopsy from a big complex tumor. It might hit a really bland, purely myxoid area, and you could end up calling it benign, totally missing a malignancy lurking right next door. That's a potential disaster. So as you move to independent sign-out, you really need to push for adequate sampling, or ideally advocate for complete excision when feasible, just to be sure you're seeing the whole picture. It's about protecting your patient and protecting yourself.
Absolutely. Can't make the call on incomplete information. Now, after looking at the morphology, a lot of pathologists, especially newer ones, might immediately jump to immunohistochemistry, IHC. It's such a workhorse for us. So, is IHC the magic bullet here for sorting out these myxoid tumors?
You're right to ask that IHC is everywhere in path, but the answer here, and our source is pretty explicit about this, is not always. In fact, IHC is specifically noted as being limited when you're trying to distinguish among the fibroblastic and myofibroblastic lesions within this group. This is a really crucial practice point for you. Don't expect IHC alone to solve everything when you're looking at two similar-looking spindle cell things in a myxoid background. However, it can be very helpful for confirming the line differentiation for other tumors that just happen to have mycoidostroma. Think about nerve sheath tumors, S100 is your friend there, or synovial sarcomas, which should light up with EMA keratins TLE1. In those cases, IHC helps confirm the bigger category, even if it doesn't perfectly separate two very similar myxoid fibroblastic lesions.
Okay, so IHC is helpful for some things, but not the ultimate decider between, say, two fibroblastic mimics.
Exactly, and this is where, modern pathology really shines. Beyond the H&E stain and the IHC, ancillary tools like cytogenetics and molecular genetics are often indispensable. They're game changers. Things like phasage fluorescence and situ hybridization, which lets us actually see specific genetic rearrangements on the chromosomes, or next-generation sequencing, NGS, which can rapidly pinpoint specific translocations or mutations that define certain tumors. These molecular fingerprints, these genetic signatures, often give you the definitive answer. They corroborate a diagnosis when morphology and IHC might still be a bit fuzzy. They're absolutely essential tools for confident, accurate sign-out today. You need to know when to reach for them.
Right, the molecular is often the final piece of the puzzle. Now, it's easy to get sort of tunnel visioned on mesenchymal tumors when you see all that myxoid stuff, right? That's what we usually associate it with. But do other tumor types ever show prominent myxoid change? Can they throw a real curveball into the differential, forcing you to think outside that mesenchymal box?
Oh, absolutely. That's a great point. The differential diagnosis isn't just limited to primary myxoid mesenchymal tumors. You have to keep a broad perspective. Our sources are clear that some other soft tissue neoplasms occasionally show really prominent myxoid stroma, enough to make them look deceptively like one of the primary myxoid tumors. Think peripheral nerve sheath tumors, DFSP, dermatofibrosarcoma protuberans, synovial sarcoma, even solitary fibrous tumor, SFT. In those cases, the key is often finding subtle conventional histologic features somewhere else in the tumor that give away its true identity. Or you rely heavily on those specific ancillary studies we just mentioned, like S100 for nerve sheath or STAT6 for SMT, and even more rarely, but definitely something to keep in the back of your mind, non-mesenchymal tumors like carcinoma and melanoma can present with significant myxoid stroma. That, my friend, is a true diagnostic curveball. Requires a high index of suspicion and a really broad differential.
Wow, okay. Metastatic carcinoma with mycosoid stroma. That's definitely something to remember. Okay, let's dive into the specific entities now, starting on the benign end of the spectrum. When you see a mycosoid lesion, especially on the hand or wrist, your mind probably jumps to the most common soft tissue lesion there, the ganglion cyst. What do we absolutely need to remember about this reactive thing? especially to avoid calling it something worse.
Yeah, ganglion cyst is super common, and it's important to remember it's a reactive lesion, not a true neoplasm. That's key. It seemed to result from myxoid degeneration of connective tissue, often linked to minor trauma or just repetitive stress. Clinically, yes, most common in hands and wrists, especially the back of the wrist. But you can see them near other joints too, knees, ankles, feet. Slightly more common in men, usually fourth to sixth decades. Often they're asymptomatic, just a lump, but they can cause pain or be a palpable mass the patient notices.
And what do they look like under the scope?
Grossly, they're usually small, pretty well circumscribed, often feel like they have a thick, fibrous pseudocapsule, frequently attached to tendons or bursae, sometimes even connect to the joint space. Histologically, they can be one big space, uniloculated, or multiple smaller ones, multiloculated. They're filled with this clear, thick, viscous fluid, essentially pure acellular mucin, like clear jelly, and the lining. It's just flat, spindled cells, probably fibroblastic or myofibroblastic. Crucially, it's not synovium, which you might expect near a joint. Okay, acellular mucin, fibrous pseudocapsule. Sounds straightforward, but are there pitfalls? Yes. There's a major diagnostic pitfall here, especially for someone new to sign out. Ruptured ganglion cysts. When these things rupture, that thick mucin can leak out into the surrounding connective tissues, and when that happens, it can create a pattern that looks exactly like an infiltrative myxoid soft tissue tumor spreading through the tissue. Recognizing this pseudo-infiltration is a huge aha moment. It stops you from overcalling a simple ruptured cyst as something much worse, like a sarcoma. Look to that acellular mucin pool and the bland reactive look of the surrounding tissue.
Wow, okay. Pseudo-infiltration from a ruptured cyst. That's a huge pearl. What else might you confuse it with?
Well, in the differential, you'd think about juxtaarticular myxoma, which we'll get to. But that usually affects larger joints, is more cellular, has more prominent stroma rather than just a cellular mucin, and usually has ill-defined borders. It lacks that clear pseudocapsule. Then there's myxo-inflammatory fibroblastic sarcoma that likes the distal extremities too, but it's a low-grade sarcoma. It'll have alternating hypo and hypercellular areas, a prominent chronic inflammatory infiltrate lymphocytes, plasma cells, and crucially, scattered large, ugly pleomorphic cells with big nucleoli. Ganglion cysts have none of that. No inflammation, no atypical cells. Prognosis for ganglion cysts is excellent, benign. Simple excision or even just aspiration often works. Recurrence isn't common. Just remember that rupture phenomenon. It's a classic mimicker.
That pseudo-infiltration point is definitely logged away. Great tip. Okay, speaking of benign but maybe deeper lesions, let's shift to intramuscular cellular myxoma. How does this one present a sort of similar but distinct challenge? What are its key features?
Right, intramuscular and cellular myxomas. These are benign but typically deep-seated tumors, again with lots of myxoid stroma. Cellular myxoma isn't really a separate entity, just a morphologic variant that happens to be more cellular, maybe has a bit more collagen. But critically, it keeps its benign cytologic features, still looks bland. These can pop up sporadically, or sometimes they're associated with Mazabrod syndrome, that rare thing where you get intramuscular myxomas plus fibrous dysplasia of bone.
And clinically, who gets these and where?
Clinically, they tend to affect middle-aged adults, median age maybe 50, 60 years. And there's a definite female predominance, about 3 to 1. Patients usually come in with a painless, slowly growing mass, most frequent spot. Lower extremities, especially the thigh, and as the name suggests, mostly intramuscular, deep within the muscle, though some can be subcutaneous.
And pathologically, what are the key things to see?
Grossly, they're often pretty big, maybe 5–10 centimeters. Usually well circumscribed, sometimes a thin fibrous pseudocapsule. Cut surface is typically gelatinous, might have some cystic change. Histologically, the classic intramuscular myxoma is uniformly hypocellular, just sparse, small, bland spindle and stellate cells floating around. They have oval nuclei, really inconspicuous nucleoli, not much cytoplasm, all in that abundant watery myxoid matrix. You'll see scattered small blood vessels. A key feature, though, is that they often infiltrate the adjacent muscle or fat tissue. But it's a non-destructive infiltration. The muscle fibers might be separated but not destroyed. Mitosis are rare, may be absent, and importantly, no necrosis. The cellular variant, as the name implies, just has areas that are more crowded with cells, can be focal or diffuse. Maybe a bit more collagenous stroma too, but crucially, the cells in these hypercellular areas still look bland. No real nuclear atypia, no pleomorphism, no significant mitotic activity to suggest malignancy. Still looks benign cytologically.
Okay, bland cells, hypocellular mostly, non-destructive infiltration. What about IHC? Any traps there?
IHC-wise, they're often CD34 positive, but consistently negative for SMA, desmin, and S100 protein. However, and this is a critical diagnostic pitfall for you, EMA can sometimes be focally positive. especially if you only have a small core needle biopsy. This can be really misleading because other myxoid things, like perineuriomas, are also EMA positive. So you need to be aware of that potential overlap, especially on limited samples. Don't hang your hat on focal EMA positivity.
Ah, the EMA pitfall on cores. Good to know. Is there a molecular tiebreaker?
Yes, absolutely. Molecular genetics is often the definitive confirmation here. Intramuscular and cellular myxomas very often harbor activating mutations in codon 201 of the GNAS gene. This mutation makes a G protein overactive, stimulating cyclic AMP, and it's a really key genetic signature. It helps confirm the diagnosis and distinguishes it from many lookalikes that don't have this mutation.
Okay, GNAS mutation is the key. How does it stack up against its mimics in the differential?
Right, differential. First, low-grade myxofibrosarcoma. The big difference there is the presence of nuclear pleomorphism, even if subtle, and those distinctive curvilinear blood vessels. Intramuscular myxoma, even the cellular variant, lacks true pleomorphism. Then, low-grade fibromyxoid sarcoma, LGFMS. Usually younger patients, alternating myxoid and collagenous zones and characteristic arcades of thin-walled vessels. LGFMS is also more uniformly cellular, often MEC4 positive, sometimes EMA positive too, and has that specific FUS gene translocation. Totally different beast. And finally, myxoid nerve sheath tumors. Things like myxoid neurofibroma, which has wavy S100 positive nuclei, or soft tissue perineurioma with its whorls, elongated cells, and EMA positivity. Remember that EMA pitfall with intramuscular myxoma cores. Claudin 1 can also be positive in perineurioma. Sometimes if you only have a tiny biopsy and the EMA is tricky, you might have to settle for benign myxoid spindle cell neoplasm initially and recommend further sampling or molecular. Prognosis for intramuscular cellular myxomas is excellent. Low risk of local recurrence, even if incompletely excised.
Simple surgical excision is usually curative.
That GNAS mutation and the EMA trap on cores are definitely key takeaways. Now, you mentioned juxtaarticular myxoma earlier as a differential for both ganglion cysts and intramuscular myxoma. Let's dig into that. You said it looks similar to intramuscular myxoma but is genetically distinct. How so?
Exactly. Juxtaarticular myxoma is fascinating because morphologically, it could look almost identical to intramuscular or cellular myxoma, but genetically, it's definitely different. Clinically, it tends to affect men more often, maybe 2.6 to 1 male-female ratio. Median age is 6 decades. And as the name juxtaarticular implies, it usually arises right next to large joints. The knee is the most common site by far over 85% of cases, followed by shoulder, elbow, hip, ankle. Patients present with a mass, sometimes pain or tenderness. Occasionally, there's a history of trauma or osteoarthritis, maybe hinting at a reactive component.
Okay, near large joints, knee especially. What about the histology?
Grossly, usually 2 to 6 centimeters, mucoid or gelatinous, soft, often has cystic degeneration. Histologically, it typically shows an infiltrative growth pattern, subtly trapping adjacent fat or tendon tissue. Cells are uniform, small ovoid, bland nuclei in myxoid stroma. Mostly hypocellular, but like intramuscular myxoma, areas of increased cellularity are common, resembling the cellular variant. Interestingly, about 90% show some features that overlap with ganglion cyst, maybe a fibrous pseudocapsule fragment or areas of cellular myxoid matrix. You might also see foci of hemorrhage, chronic inflammation, fibrin deposition, possibly related to trauma, again suggesting maybe it's not purely neoplastic.
Okay, sounds very similar to intramuscular myxoma histologically. IHC, genetics.
IHC is pretty nonspecific. Variable CD34 or SMA positivity, S100 is negative. Doesn't help much. But the crucial differentiating factor, the real nugget here, is the molecular genetics. Juxtaarticular myxoma lacks those activating GNAS gene mutations that are characteristic of intramuscular and cellular myxomas. This molecular difference confirms they are separate entities, even though they look so alike under the microscope. This is the key differentiator you rely on.
Wow, so same look, different location, different genetics. That's a critical distinction.
Exactly. It's a perfect example of why integrating location and molecular is so important. So for the differential, ganglion cyst affects smaller joints usually, has purely a cellular mucin, dense pseudocapsule. Intramuscular myxoma is histologically almost identical, as we said. They're distinguished only by anatomic location, adjacent to joints versus within large muscles, and the absence of the GNAS mutation in juxtaarticular myxoma. That's a real aha moment, same look, different place, different name, different gene status. And low-grade myxofibrosarcoma is usually superficial, rarely involves joints directly, and crucially has nuclear atypia and those characteristic curvilinear blood vessels, which juxtaarticular myxoma lacks entirely. Prognosis for juxtaarticular myxoma, local recurrence is seen in about 35% of cases, which is higher than intramuscular myxoma, something to be aware of, but it has no metastatic potential. Complete surgical excision is generally curative.
That's a fantastic example of integrating all the data points. Location, morphology, molecular. Crucial for sign out. Okay, moving to the skin now. Let's talk about dermal nerve sheath myxoma, which used to be called mycosoid neurothekioma. How do we pin this one down, especially given its potential to come back?
Right, dermal nerve sheath myxoma. Yeah, it was confused with cellular neurothekioma for a while, but it's definitely distinct. It's a true Schwann cell neoplasm. Clinically affects men and women equally, tends to be younger adults, mean age around 35. Patients usually present with small, painless nodules, often on the distal extremities, fingers, toes, or common spots.
And pathologically, what's the look?
Pathologically, it's usually a well-circumscribed small nodule, maybe zero point 0.5 to 2 centimeters, primarily dermal, but often extends a bit into the subcutaneous tissue. It has a very characteristic lobulated growth pattern. Sharply demarcated lobules, often separated by fibrous bands. Within these lobules, there's abundant myxoid matrix. The tumor cells grow in a reticular, sort of net-like pattern, and they often form these distinctive circular or ring-like structures, especially at the edges of the lobules. That's a good clue. The cells themselves are spindled to stellate, maybe slightly hyperchromatic nuclei, not much cytoplasm. Mitoses are scarce, minimal nuclear pleomorphism, looks benign cytologically.
Okay, lobulated, reticular, ring-like structures. What about IHC? You mentioned that Schwann cell.
Yes, and IHC is absolutely key here. This is your diagnostic nugget.
Yeah.
Dermal nerve sheath myxoma diffusely expresses S100 protein, usually GAF positive too in most cases. This confirms its Schwann cell nature unequivocally. That strong, diffuse S100 is critical.
Okay, S100 is the key stain. How does that help with the differential?
It helps a lot. For example, cellular neurothekioma likes the head, neck, upper extremities. It's poorly circumscribed, micronodular, has epitheliate cells, and myxoid stroma is rare. Crucially, it's NKIC3 positive, but S100 negative, so IHC clearly separates them. Plexiform neurofibroma can be superficial, multinodular plexiform, but it's not uniformly myxoid, usually less diffusely. S100 positive might has an EMA, shows axons with neurofilament protein, and is linked to NF1. Different picture. Superficial angiomyxoma is usually poorly circumscribed, ill-defined lobules, often has those stromal neutrophils we talked about, and importantly, it's S100 negative. And low-grade myxofibrosarcoma, while it can be lobulated and infiltrative, affects older folks. It has those curvilinear vessels, definitely has atypical hyperchromatic cells, and is also S100 negative. Prognosis for dermal nerve sheath myxoma. It does have a relatively high rate of non-destructive local recurrence, maybe up to 45% after simple excision. But importantly, no metastatic potential. It's benign.
That strong S100 positivity is definitely a clear anchor point for nerve sheath differentiation. Now, let's talk about a lesion that sounds common but maybe under-recognized, especially because it pops up on fingers and toes. Superficial acral fibromyxoma, also called digital fibromyxoma. What should we know to correctly identify this one?
Yeah, superficial acral fibromyxoma. It is relatively common, but can be overlooked or misdiagnosed if you're not familiar with it. Clinically, affects adults, slight male predominance, usually presents as painless nodules on fingers and toes, often right around the nail bed. Periungual location is very typical.
Periungual nodules? Okay.
Yeah.
What's the histology?
Pathologically, it's usually a small polypoid or dome-shaped skin lesion. The epidermis over it is usually intact, no ulceration. It's poorly circumscribed, unencapsulated, sits mainly in the dermis. It's made of the cellular proliferation of these elongated or stellate-shaped fibroblasts that look cytologically uniform, very bland, arranged in a sort of haphazard random pattern. The stroma is variably collagenous or metexoid. Critically, no nuclear atypia. Mitoses are rare, no necrosis. All features point towards benign.
Bland fibroblasts, haphazard pattern, variable stroma, IHC helpful, molecular.
IHC is pretty limited value here, no single magic bullet stain. The cells are usually diffusely CD34 positive. Sometimes you might see occasional EMA positivity, but S100 is consistently negative. Molecular genetics, however, offers a key insight, although it's not routine testing yet. Recent studies show monoallelic deletions of chromosome 13q12, which includes RB1 tumor suppressor gene. So loss of RB1 expression is common and can help confirm if needed.
Okay, RB1 loss is the molecular clue. How does it differ from its mimics?
Differential diagnosis. Superficial angiomyxoma typically arises on the trunk, head, neck, has more abundant myxoid stroma, lobulated growth, and often those scattered neutrophils, which you don't see in superficial acral fibromyxoma. Myxoid benign fibrous histiocytoma is very rare to have prominent myxoid stroma. You'd look for typical areas with that lateral entrapment of dermal collagen, and most are CD34 negative, unlike acral fibromyxoma. The rare myxoid dermatofibrosarcoma protuberans, DFSP, can be tricky, especially if it's on a digit. But for DFSP, you need to find that typical store-form architecture and the diffuse infiltration of that honeycomb pattern. Both are CD34 positive, so morphology and infiltration pattern are key. And soft tissue paraneurioma is usually subcutaneous, well-circumscribed, shows storiform, whorled, or lamellar patterns. It's CD34 positive, consistently EMA positive, and sometimes Claudin-1 positive. Again, different architecture.
Okay, so location, architecture, neutrophils, and specific IHC markers help sort those out. Prognosis.
Prognosis is benign. But, like dermal nerve sheath myxoma, local recurrence can be up to 25%. Especially those tricky periungual lesions where getting clean margins is tough. No potential for metastasis, though. So, your practice points. Adults, slight male predominance, periungual finger stows, poorly circumscribed dermal lesion, bland fibroblasts, haphazard pattern, mixed myxoid collagenous stroma. Remember, RB1 loss deletions is the molecular marker. High local recurrence rate, but benign.
All right, another one where benign doesn't mean zero recurrence. Good point. Let's move to superficial angiomyxoma. You mentioned this as a differential earlier. It's another distinct cutaneous lesion, also with recurrence potential but benign. What are its defining features?
Superficial angiomyxoma, yes. It's a distinctive cutaneous mesenchymal lesion, and corrected also have that propensity for local recurrence, but no metastatic risk. Clinically, typically middle-aged adults, slight male predominance again, presents as a painless, slowly growing nodule, most common sites, trunk, head, and neck. External genital area can be affected too, maybe more often in women there. And an important practice point, a small subset is associated with Carney complex, especially lesions on the external ear and breast. So clinical context can be a clue.
Carney complex association. Okay. What about the pathology?
Pathologically, it's typically a hypocellular dermal lesion with really abundant myxoid stroma. It forms ill-defined lobules that often subtly infiltrate into the subcutaneous tissue. The cells are small, spindled or stellate, with ovoid, vesicular nuclei, inconspicuous nucleoli, and not much cytoplasm. Small blood vessels are usually quite prominent throughout the myxoid background. Now, a diagnostic nugget that's helpful. Scattered neutrophils are seen in about half of cases. These aren't usually linked to necrosis or ulceration, so they're not inflammation in the usual sense, but rather seem to be an intrinsic feature of the tumor. Seeing neutrophils in a bland myxoid lesion should make you think of this. About 20% can also have entrapped epithelial structures, like little epidermoid cysts or strands of squamous epithelium caught within the tumor. Another subtle clue. And crucially, like other benign lesions, no nuclear atypia or pleomorphism.
Okay, hypocellular, myxoid, prominent vessels, and maybe neutrophils or entrapped epithelium. IHC.
IHC typically shows CD34 positivity, consistently negative for S100 desmin and keratins. Another nugget here on the molecular side is the loss of PRKAR1A expression by IHC, which is seen in up to 2/3 of tumors. Molecular genetics confirms this link. Both sporadic cases and those associated with Carney complex often have inactivating mutations in the PR1A gene. This genetic link underlies its association with Carney complex.
PRKR1A mutations. Got it. Differential diagnosis.
In the differential, dermal nerve sheath myxoma prefers digits, has sharply demarcated lobules, and is strongly S100 positive. Clear distinction. Deep aggressive angiomyxoma. This characteristically affects the genital area, similar to some superficial ones, but it arises in deeper soft tissue. It's diffusely infiltrative and has that highly characteristic vascular pattern with smooth muscle cells spinning off the vessel walls. You won't see that in the superficial variant. Low-grade myxofibrosarcoma, more common in the elderly, usually on extremities, has those curvilinear vessels and scattered atypical pleomorphic cells, features absent in superficial angiomyxoma. Prognosis. High rate of non-destructive local recurrence, around 30%, but no potential to metastasize. Complete surgical excision is curative, so key practice points. Middle-aged adults, trunk, head, neck. Hypocellular dermal lesion, abundant myxoid stroma, ill-defined lobules, prominent vessels, maybe scattered neutrophils. Remember, PRAR1A mutations are associated. High local recurrence, but benign behavior.
That distinction between superficial and deep angiomyxoma depth and that unique vessel pattern seems really crucial. So let's move on to deep angiomyxoma, also known as aggressive angiomyxoma. You mentioned that spinning off vessel pattern. Can you elaborate on its unique characteristics and why, despite that aggressive name, it's rarely truly aggressive?
Yes, deep angiomyxoma, or aggressive angiomyxoma.
Yeah.
It's a distinctive tumor, primarily of the gynecologic soft tissues, but occasionally seen in males in the scrotal or perineal region. And yes, that name aggressive is a bit of a misnomer in terms of metastatic potential. It rarely behaves truly aggressively in that sense. Clinically, it mainly affects young to middle-aged adult women. Presence as a mass or swelling in the pelvic, perineal, or scrotal areas, vulva, vagina, inguinal region, pelvis, are common sites.
Deep pelvic perineal mass in young women often. Gross and histo.
Grossly, it's typically a large, deep-seated mass. And importantly, it has infiltrative margins. It doesn't shell out easily. Histologically, it's a hypocellular neoplasm, composed of small, monomorphic spindle cells just floating in an abundant myxoid or edematous stroma. The absolute key diagnostic feature, the ultimate nugget for this entity, is the vasculature. You see small to medium-sized blood vessels that often have perivascular hyalinization, this sort of glassy cuff around them. And then, characteristically, you see smooth muscle cells literally spinning off the vessel walls, forming a kind of collar or sleeve around the vessels. This unique vascular pattern is highly characteristic, almost pathognomonic. If you see that, you should strongly consider deep angiomyxoma.
That spinning off pattern sounds really unique. A great visual clue. IHC, molecular.
For IHC, deep angiomyxoma consistently shows overexpression of HMGA2 protein, and molecular genetics backs this up. Recurrent translocations involving chromosome 12q15 lead to rearrangement of the HMGA2 gene. This is a crucial molecular fingerprint that helps confirm the diagnosis.
HMGA2 rearrangement, okay. How does it compare to other things in that area?
Differential diagnosis focusing on myxoid variants in that region. Cellular angiofibroma also affects vulvovaginal and gracrudal areas, but it has short spindle cells, more delicate collagen, numerous small, round, often hyalinized vessels, but not the spinning off pattern, and it shows loss of nuclear RB1 expression. Superficial angiomyxoma, as we discussed, involves skin subcutis, not deep tissue, and lacks the deep infiltrative pattern in those characteristic vessels. Myxoid DFSP is rare, can rarely affect the genital scrotal region, but it's poorly circumscribed and very hard to recognize without finding typical DFSP areas elsewhere. An embryonal rhabdomyosarcoma, Botryoi variant, arises at mucosal sites, classically shows a cambium layer, dense cells into the epithelium, and is myogenin positive by IHC. Prognosis. Despite the name, rarely truly aggressive. Usually cured by simple but complete local excision, no potential for distant metastasis. Early studies suggested high recurrence, but more recent data suggests recurrence is actually pretty rare if you get clear margins. Key practice points. Young to middle-aged adult women primarily. Pelvic perineal scrotal areas. Deep-seated, infiltrative. Monomorphic spindle cells, myxoid stroma, and those distinctive spinning-off smooth muscle cells from vessels. HMGA2 expression rearrangement is your molecular key. Local recurrence possible but uncommon with good surgery, no metastatic potential.
That spinning off vessel pattern is definitely one to burn into memory. Okay, next up. Ossifying fibromyxoid tumor, OFMT. This one sounds tricky, uncertain differentiation, and it can be benign, atypical, or malignant. How do we sort this one out?
OFMT, yes. It's a bit of an oddball. Tumor of uncertain differentiation, usually benign, but a small subset, maybe less than 10%, can be atypical or frankly malignant, which is why recognition is important. Clinically affects adults, median age 50, slightly more common in men, maybe 1.5, 2.1. Found in upper and lower extremities, trunk, head, neck. Typically presents as a slowly growing, long-standing, painless mass, either subcutaneous or intramuscular.
Okay, slow-growing mass may be subcutaneous. What about the path features? That ossifying part sounds key.
Yes, the ossification is key. Grossly, OFMT is usually well circumscribed, multinodular, averages maybe 4 to 5 centimeters, typically subcutaneous, often attached to tendons or fascia, has a fibrous or fibroosseous pseudocapsule. Histologically, the typical OFMT is lobulated, and in over 80% of cases, it's surrounded by an incomplete shell or rim of lamellar bone. This peripheral bone is a major nugget that helps confirm the diagnosis. Non-ossifying examples are less common. Interestingly, about 15% can actually invade through that pseudocapsule, forming little satellite nodules nearby, which can mimic how pleomorphic adenoma behaves. The tumor itself is composed of monomorphic round to ovoid cells. They're arranged in cords or trabeculae within a stroma that's variably fibromyxoid. Mitosis are scarce in typical cases.
Peripheral bone shell, monomorphic cells, and cords. Okay, now the crucial part. Distinguishing typical from atypical malignant. How do we do that?
Right, this is critical for prognosis and management. Atypical or malignant OFMT accounts for less than 10% of cases. They show features linked to more aggressive behavior. Things like hypercellularity, being packed with cells, having more than 2 mitosis per 50 high-power fields, necrosis, vascular invasion, moderate or severe nuclear atypia, ugly nuclei, or bone that's located centrally or randomly scattered within the tumor rather than forming that nice peripheral shell. For a definitive malignant diagnosis, you need either high nuclear grade, meaning really ugly nuclei, or the combination of high cellularity plus more than 2 mitosis per 50 HPFs. It's considered atypical if it has some of these concerning features, but doesn't quite meet those strict criteria for malignancy. Be aware, if you see significant atypia along with osteoid production, it can rarely mimic osteosarcoma.
Okay, clear criteria for malignant. High-grade nuclei or high cellularity plus high mitosis, IHC.
IHC-wise, most OFMTs, maybe 70–90%, are S100 protein positive, although it can sometimes be focal. Desmin is positive in up to 50%. Focal keratins, or EMA, are seen in less than 10%. MUC4 can be positive in a small subset, interestingly. Molecular genetics is quite characteristic and offers a definitive nugget. Recurrent rearrangements of the PHF1 gene are typical. This could be confirmed by FISH. A subset has a specific PHF1 EP400 fusion. Other rare fusions exist, but PHF1 rearrangement is your key molecular finding.
PHF1 rearrangement, good.
Differential diagnosis.
Yeah.
Soft tissue myoepithelioma. That generally shows more intratumoral heterogeneity, different cell types, different growth patterns. It's usually S100 plus keratin plus AMA plus 80–50%, GFAP plus AF, but typically Desmin negative. And about half have EWSR1 rearrangements. OFMT is often Desmin positive. Extraskeletal myxoid chondrosarcoma, EMC. That is much more abundant in myxoid stroma. Larger spindled epithelioid cells, a uniform reticular architecture. S100 positive and less than 20%, consistently Desmin negative. And confirmed by the T922 involving EWSR1 and NR4A3. Different molecular signature.
Okay, so heterogeneity and IHC molecular help there. Prognosis difference.
Yes, prognosis varies significantly. Surgery is the treatment. Typical OFMT recurrence may be 10–20%. Metastases are rare, 2%. Atypical OFMT. Similar recurrence metastasis rates to benign, surprisingly, but malignant OFMT, high risk, about 60% local recurrence or metastasis rate. That's why accurate grading is so critical. Key practice points for OFMT. Adults, male predominance, extremity, strong head neck, lobulated mass, incomplete bone shell, monomorphic ovoid cells and quartz trabeculae, variable fibromyxoid stroma. Remember those malignancy criteria? S100 plus BIS, often Desmin plus ESO, PHF1 rearrangements are frequent and key.
That distinction between typical, atypical, and malignant OFMT based on those criteria is incredibly important for patient management, especially follow-up. Now let's move to myoepithelioma. You mentioned it earlier as part of a spectrum. What defines the benign end of the spectrum, and what pitfalls should we watch out for?
Right, myoepithelioma. It's part of a morphologic continuum ranging from benign mixed tumors, which have ductal structures, to pure myoepithelioma, lacking ducts, and then to myoepithelial carcinoma. It's analogous to what we see in salivary glands. Clinically, peaks in adults, 3rd, 5th decades, equal gender distribution usually. Though it's worth noting, the malignant version, myoepithelial carcinoma, is proportionally more common and aggressive in kids. That's an important point. Patients usually present with a palpable mass, may be painful, maybe not. Most common sites, limbs and limb girdles, about 75% of cases. Then head, neck, trunk. Occur equally in subcutaneous and deep soft tissue.
Okay, adults mostly, limbs common, gross appearance, histology.
Grossly, average maybe 3.5 to 4 centimeters. Usually well circumscribed, often lobulated, might have a thin pseudocapsule. Cut surface is firm, often myxoid or glistening, reflecting that stroma. Histologically, myoepithelioma most often shows a reticular sort of net-like growth pattern with prominent chondromyxoid or hyalinized stroma. Those sheets of cells can occur too. A key diagnostic feature is often significant intratumoral heterogeneity. Mixed patterns are common. You see different looks within the same tumor. The neoplastic cells themselves can be arranged in cords, sheets, nests. They can be epithelioid, roundish, or spindled, usually with eosinophilic cytoplasm. A classic nugget to look for are plasmacytoid cells, cells with nuclei pushed to the side, and glassy hyaline cytoplasm. These can be focal or extensive. Other features you might see: focal, clear cell areas, even attempts at ductal, squamous, or adipocytic differentiation. Sometimes even metaplastic cartilage or bone can pop up.
Wow, lots of potential variability there. Heterogeneity is key. What about IHC?
IHC is quite characteristic and provides several key nuggets. Myoepitheliomas are almost always positive for at least one broad-spectrum keratin or EMA. That highlights their epithelial side. Most are also S100 positive. About half are GFA positive, often calponin positive, SMA positive, and around 30%. But usually Desmin negative. P63 is positive in up to 45%, and SOX10 at about 80%. Mixed tumors with ducts often show nuclear staining for PLAG1, and sometimes, especially in the carcinomas, you see loss of SMRCB1, INI1 expression, which can be a clue to aggressive behavior, particularly in kids. Okay, so keratinema and S100 are the mainstays. Molecular findings. Molecular genetics. About 50% harbor EWSR1 gene rearrangements with various fusion partners. Variant FUS rearrangements can also occur. Mixed tumors often have PLAG1 gene rearrangements instead.
EWSR1 is common. How does myxoid myoepithelioma differ from its mimics?
Differential from myxoid myoepithelioma, OFMT, which we just discussed. OFMT generally lacks that intratumoral heterogeneity, is typically Desmond positive. Myoepithelioma is usually negative, and rarely keratinema positive. Extraskeletal myxoid chondrosarcoma, EMC. EMC is usually very uniform looking, less often S100 positive, usually negative for keratin sag fat. While both can have EWSR1 rearrangements, NR4A3 FAISH is specific for EMC. That's your definitive tiebreaker there. And epithelioid schwannoma can have epithelioid cells in chord's nests, often lobulated, sometimes prominent myxoid stroma. It's strongly diffusely S100 and GFA positive. But crucially, it's negative for keratins. Some also show SMRCB1 loss.
Okay, IAT panel and maybe molecular are key to sorting those out. Prognosis of benign myoepithelioma.
Prognosis and treatment. Complete surgical excision is the goal. They recur in about 20% of cases, sometimes due to incomplete excision or that infiltrative edge, but they very rarely metastasize. Considered benign overall. Key practice points for myoepithelioma. Adults, 3rd, 5th decades, limb-to-limb girdles common. Look for reticular growth, chondromyxoid hyalinized stroma, and that intratumoral heterogeneity. Epithelioid or spindled cells, maybe plasmacytoid IHC, keratins plus ARMA plus ARA, SEA plus ARA, AS100 plus ARA. Remember the 20% recurrence rate, but metastases are rare.
That heterogeneity sounds like a key feature to recognize. Now, what flips the switch to malignancy? What defines myoepithelial carcinoma, and how aggressive is it? You mentioned it's worse in kids.
Yes, myoepithelial carcinoma is the malignant counterpart, and the single most important criterion for calling it malignant is the presence of nuclear atypia. Clinically, features are similar to myoepithelioma, but carcinomas tend to be larger, maybe grow faster. And yes, as we noted in kids, they're proportionally more common and significantly more aggressive. That's a major concern.
Larger, faster growing. What defines malignancy under the scope?
Grossly, usually larger than benign ones. Can be firm or fleshy. Might see calcification or necrosis, especially in bigger tumors.
Yeah.
Histologically, the number one diagnostic nugget for malignancy is at least moderate nuclear atypia. You need to see enlarged nuclei, maybe vesicular or coarse chromatin prominent nucleoli, just ugly nuclei. Now, features like infiltrative margins, a high mitotic rate, or necrosis might be present and definitely raise suspicion. But those features alone aren't enough to diagnose malignancy. You can have a tumor with really marked nuclear atypia, but maybe low mitosis that can still be aggressive. So always prioritize that nuclear cytology. It's the most reliable indicator of malignant potential.
Okay, nuclear atypia is the key criterion. IHC profile similar. Any malignancy markers?
Immunohistochemically, the profile is pretty much the same as benign myoepithelioma. Keratins plus I, EMA plus S100 plus I, GFAP plus I, calponum plus O, P63 plus I, SOX10. However, a crucial nugget that can suggest a more aggressive phenotype, especially in kids, is that S-MARCB1 INI1 loss. Seen in about 10% of adult cases, but maybe 40% in children. Loss of INI1 is a bad sign here. Molecularly, EWSR1 gene rearrangements are still found in about 50% of cases. Variant FUS rearrangements can also occur. Similar genetics to benign, but now paired with malignant morphology.
Okay, INI1 loss is a flag, especially in kids. Differential diagnosis for the carcinoma.
Differential for myxoid myoepithelial carcinoma. Metastatic carcinoma can rarely be myxoid. It's keratin positive, but usually S100 negative, GFAP negative, myogenic markers negative. Helps distinguish it. Malignant melanoma also rarely myxoid. Typically HMB45 plus melon A plus myopus 100 plus SOMID, negative for keratins EMA. And proximal type epithelioid sarcoma. Has large epithelioid cells, prominent nuclei, sometimes a myxoid background. Like myoepithelial carcinoma, it's keratin plus home, EMA plus HOSOM, but differs by being CD34 plus in about 50%, S100 negative, GFAP negative, and critically SMRFB1, INI1 expression, is absent in nearly all epithelioid sarcomas. That INI1 loss is much more consistent in epithelioid sarcoma than in myoepithelial carcinoma, making it a key differentiator if it's lost.
INI1 status is really important there. Prognosis and treatment for the carcinoma.
Prognosis is guarded. Complete surgical excision with negative margins is crucial. Local recurrence rates are high, around 40%. Metastatic rate is at least 30%. And in children, it's even more aggressive, maybe 50% recurrence, metastasis, and mortality. It's a bad actor in kids. Most common sites of metastasis: lung, lymph nodes, other soft tissues. Interestingly, they might be sensitive to some chemo, like carboplatin and paclitaxel, which offers a potential treatment option. Key practice points for myoepithelial carcinoma. Malignancy criterion is moderate severe nuclear atypia. EWSR1 rearrangements common. Be prepared for high recurrence and metastatic rates, lung, lymph nodes, soft tissues. INI1 loss is a significant negative prognostic factor, especially in kids.
That's a really sobering picture, particularly the stats in children, highlights why accurate diagnosis is so vital.
Okay.
Let's shift gears now to myxofibrous sarcoma. You mentioned this is the most common sarcoma in the elderly. What morphological features and nuggets really define this common but often recurrent sarcoma?
Yes. Myxofibrosarcoma, MFS. Most common sarcoma in older adults. It's the preferred name for a fibroblastic sarcoma that has a variable amount of myxoid stroma. High-grade forms can look a lot like undifferentiated pleomorphic sarcoma, UPS, which can make diagnosis tricky if you don't sample well. Clinically, slight male predominance, most common in lower limbs, thigh especially, limb girdles, then upper extremities. Usually superficial in the subcutis or dermis. About a third are deep-seated subfacial. Typically presents as a painless mass, often slowly enlarging. Important point. If you see something that looks like this in the retroperitoneum or body cavities, think twice. It's often more likely to be dedifferentiated liposarcoma, not primary MFS. Location matters.
Okay, elderly, lower limbs, often superficial, gross appearance, key histology.
Grossly, usually all large multinodular mass. Characteristically has infiltrative margins, which explains why it comes back so often. Cut surface is variably myxoid and firm. Hemorrhage or necrosis are more common in higher grades. Histologically, a key diagnostic nugget is its lobulated pattern. Often shows alternating hypocellular myxoid areas and more hypercellular fibrous areas. In low-grade MFS, you see mostly hypocellular myxoid areas. There are scattered atypical, mildly pleomorphic cells. Even low-grade has some atypia. And the prominent curvilinear blood vessels are a very helpful, almost pathognomonic nugget for low-grade MFS. Thin, elongated, curvy vessels. You might also see pseudolipoblast tumor cells with cytoplasmic mucin vacuoles pushing the nucleus aside. But they aren't true lipoblasts like in liposarcoma. Higher grade forms are mostly hypercellular. More prominent fibrous stroma, much more obvious nuclear atypia. Can look just like UPS if you don't hunt for those myxoid areas and curvy vessels. Any hypercellular area usually bumps it up to at least intermediate grade. Rarely you can see epithelioid tumor cells mimicking melanoma or carcinoma, but usually mixed with conventional areas.
Okay, lobulated, alternating cellularity, pleomorphism even in low grade, and those curvilinear vessels. Grading is key.
Yes, grading is crucial for prognosis. It's a three-tier system, low, intermediate, high, based mainly on cellularity and how much non-myxoid component there is. IHC has a limited role diagnostically, mostly used for excluding other things. You might see focal CD34 or SMA, usually negative for Desmond, S100 keratins. Molecular genetics isn't very specific either. Usually shows a complex karyotype with lots of numerical and structural abnormalities. No single translocation defines it. Recurrent cases often get even more complex genetically.
Complex karyotype, differential diagnosis depends on grade.
Exactly. For low-grade MFS, differential includes cellular myxoma, nuclear pleomorphism, myxoid neurofibroma, S100 positive, low-grade MPNST, lacks classic curvilinear vessels, maybe less pleomorphism for similar cellularity, 40% S100 positive, LGFMS, younger patients, alternating areas but no pleomorphism, arcading vessels, MUC4 positive. For high-grade MFS, the differential broadens to other high-grade pleomorphic sarcomas. You really need good sampling to find characteristic MFS features.
And the prognosis is tough, you said. High recurrence.
Prognosis depends on grade and depth, but yes, local recurrence is very high, 50–60%. That's independent of grade, mostly due to those infiltrative borders. It's hard to get it all out. And tumor grade often increases with each recurrence, which is bad news. Metastatic rates are grade-linked. Less than 5% for low grade, but up to about 35% for high grade. Common metastatic sites, lung, intra-abdominal organs, retroperitoneum. And unusually for sarcomas, a key nugget, it can metastasize to lymph nodes. That's important for staging and follow-up. Overall mortality is significant, around 50%. Treatment is complete surgical excision with wide negative margins, ideally 2 centimeters or an intact fascia. Adjuvant radiation might help reduce local recurrence. Chemo generally isn't very effective. Sadly, MFS is one sarcoma that still sometimes requires amputation because of uncontrolled local recurrence. Really highlights its locally aggressive nature.
Wow, 50–60% local recurrence is huge, and lymph node met's definitely key to remember. Okay, let's tackle myxoid liposarcoma. Not just the second most common liposarcoma in adults, but also the most common in kids' adolescents. What are the key features? And tell us more about those distinctive vessel patterns.
Right, myxoid liposarcoma and its higher grade counterpart, round cell liposarcoma, are really morphologic variants of the same tumor type driven by the same genetics. Clinically, affects younger adults, peak maybe 5th decade, slight male predominance. And yes, absolutely, the most common liposarcoma in children and adolescents, crucial point for pediatric path. Patients typically present with a slowly growing, painless mass. Lower extremity, especially the thigh, is the classic location. Vast majority are deep, subfacial, very few are subcutaneous. If you see something like this in the retroperitoneum, abdomen, pelvis, mediastinum, be cautious. It's rarely primary there, more likely metastasis or a mimic like well-differentiated liposarcoma.
Okay, younger adult states, deep thigh mass, gross, histo, those vessels.
Grossly, usually large, median maybe 10, 12 centimeters. Often looks well circumscribed, but can infiltrate. Gut surface is homogeneous, gelatinous, really myxoid. If you see tan white firm areas, sample those. That's usually the higher grade round cell component and it impacts prognosis. Histologically, low-grade myxoid liposarcoma is typically hypocellular, lobulated, composed of monotonous small ovoid cells. Fine chromatin, inconspicuous nucleoli, not much cytoplasm. They're floating in this uniform myxoid background, often with mucin pooling that gives a pulmonary edema-like look. The absolute key diagnostic nugget is the prominent plexiform vascular pattern. These thin-walled branching capillaries are famously described as chicken wire or crow's feet vessels, really distinctive. You also need to find small uni or bivaculated lipoblasts, primitive fat cells. They're usually focal, often easiest to spot at the edges of the lobules. Necrosis is usually absent and low grade, low mitotic rate, and importantly, no nuclear pleomorphism, very monotonous cells. High grade or round cell liposarcoma is just packed with these monomorphic rounded ovoid cells, maybe some scattered small lipoblasts. Still retains that characteristic vascular pattern, but now in sheets of round cells. High cellularity is the key.
Okay, monotonous cells, chicken wire vessels, lipoblasts, no pleomorphism. IHC, useful.
IHC generally doesn't play a big role in diagnosis. They're often S100 positive, but that's nonspecific. Importantly, they're rarely positive for MDM2 or CDK4, maybe 5%. These markers are nearly always overexpressed in well-differentiated and de-differentiated liposarcomas, so that negativity helps rule those out. Molecular genetics, however, is usually definitive. This is the ultimate nugget, most common. Valence translocation T1216, Q13P11. This fuses the DDIT3 gene, also called CHOP, on chromosome 12 with the FUS gene on chromosome 16. A variant translocation, T1222, Q13, Q12, fuses DDIT3 with UWSR1 on chromosome 22 in about 10% of cases. So cytogenetics or FFESH looking for FUS or DDIT3 gene rearrangement can absolutely confirm the diagnosis if morphology is healthy.
FUS DDI23 or UWSR1 DDIT3 fusion. Got it. Differential quickly.
Differential. Cellular myxoma, bland spindle cells, lax lobules, lipoblasts, crow's feet vessels. Well-differentiated liposarcoma with myxoid change has scattered hyperchromatic atypical cells, MDM2-CDK4 positive. EMC, cells in cords, no lipoblasts, inconspicuous vessels, different molecular NR4A3. Low-grade myxofibrosarcoma, curvilinear vessels, no true lipoblasts, scattered pleomorphism even in low grade.
Okay, molecular is key there. Prognosis and treatment. Any unusual spread patterns?
Prognosis and treatment. Overall local recurrence is around 30%. Distant metastasis about 40%, and this is directly related to histologic grade, specifically the amount of round cell component. Prognostic nuggets, having 5% round cell morphology significantly worsens outcome. Also age 45 years, presence of round cell component 5% or 25% volume, and necrosis are bad signs. Overall mortality is maybe 25-40%. Most common metastasis sites, soft tissues, especially contralateral extremity, retroperitoneum, bone, and lungs. And here's an unusual and important predilection. Myxoid liposarcoma loves to metastasize to the spine. That's a key clinical correlation for imaging and follow-up. Really important point. Treatment. Surgery. Radiation is often used for close or positive margins. Chemo role is debated, but trabectedin is an effective systemic therapy specifically for this type. Radiase can also cause cytodifferentiation, making it look more hypocellular, hyalinized with more mature fat.
That spinal metastasis predilection is definitely a critical point to remember for follow-up imaging. Huge takeaway. Now let's discuss extraskeletal myxoid chondrosarcoma, EMC. It's rare, and as you said, the name is tricky because there's no real cartilage. What defines this one?
EMC, yes. Rare, about 3% of soft tissue sarcomas. And you're right, despite the name, no convincing cartilage differentiation. That trips people up. Clinically, affects adults, peak 6th decade, more common in males, 1.5, 2.1. Limbs and limb girdles, most common, 5 buttocks especially, then upper extremities, head, neck. Less than 10% in retroperitoneum, abdomen, pelvis. Usually presents as a slowly growing, painless mass, most often deep subfacial, often associated with fascia or tendons.
Okay, older adults, deep limbs girdles. Gross.
Grossly, multinodular, usually it's well circumscribed, thin pseudocapsule. Cut surface is very myxoid soft, average maybe 7 centimeters. Cystic change and hemorrhage are common. Histologically, it's lobulated. Tumor lobules separated by fibrous septa. The cells are epithelioid to spindled, usually arranged in cords, strands, or clusters. A key morphological nugget is that they tend to accumulate at the periphery of the lobules. This peripheral condensation is helpful. They're embedded in abundant myxoid stroma. Nuclei are round, elongated, fine chromatin, small nucleoli. Moderate eosinophilic cytoplasm. Mitosis are infrequent. Necrosis uncommon in typical cases. And again, no cartilaginous differentiation, despite the name. High-grade EMC exists, shows increased cellularity, solid areas without much myxoid stroma. Hypercellularity with high mitotic rate. Necrosis. Cells are often larger, more epithelioid, prominent nucleoli. Some can even show rhabdoid features, glassy pink cytoplasmic inclusions.
Okay, lobulated, cord strands, peripheral condensation, abundant myxoid, IHC helpful.
IHC. S100 is positive in only 15–20% of cases, much less than typical nerve sheath tumors. Rarely emacrotin positive. Loss of SMARCB1, INI1 seen in a small subset, usually those with rhabdoid features. So IHC isn't super helpful usually. Molecular genetics, however, is the definitive nugget for diagnosis. It's characterized by specific balanced translocations. Most common, 50–70%, is T922Q22Q12. This fuses UWSR1 on 22 with NR4A3 on 9. Other fusions involving NR4A3 also occur with different partners like TF15, TCF12, TFG. While FISH for UWSR1 break-apart is often used since it's involved in many sarcomas, probes for NR4A3 rearrangement are actually more sensitive and specific for confirming EMC. That's an important nuance. NR4A3 rearrangement is the key molecular signature. Got it. Differential diagnosis must rely heavily on that. Yes, ancillary studies are crucial here. Differential. Myoepithelial neoplasms can be lobulated, cords, and myxoid stroma, but show more heterogeneity. Usually keratoconemius 100 positive, EMC usually negative. Both can have UWSR1, but NR4A3 FISH specific for EMC. OFMT, lobulated cords of uniform ovoid cells, but lacks abundant myxoid matrix. Has bone shell, usually S100 plus stirred, often Desmond plus PHF1 rearranged. Myxoid liposarcoma, monomorphic small spindle cells, distinctive crow's feet, capillaries, lipoblast, mucin pooling, FUS-DDIT3 fusion. Low-grade myxofibrosarcoma, usually subcutaneous, EMC, subfacial, has curvilinear vessels, scattered pleomorphism. For high-grade EMC, differential includes other epithelioid malignancies, metastatic melanoma, S100 plus thirst, SOX10 plus cerebroacidic markers plus, metastatic carcinoma, keratins plus, proximal type epithelioid sarcoma, keratins plus SOCO, EMA plus on CD34 plus MENAS100 negative INI loss.
Okay, molecular is really needed to pin down EMC. Prognosis treatment. You mentioned late meds.
Yes, prognosis is tricky because of late events. Wide surgical excision with negative margins is standard. Radiation might be used for local control. EMC has high rates of local recurrence, 35–50%, and distant metastasis, 25–50%. And crucially, metastases often occur late, sometimes decades after the initial diagnosis. This mandates long-term, potentially lifelong follow-up. Common sites: lung, lymph nodes, bone, other soft tissues. 5-year overall survival is pretty good, maybe 90%, but 10-year survival drops to around 70% because of those late metastases. Poor prognostic factors: older age, proximal location, large size, 10 centimeters, high-grade features. Key practice points for EMC: adults, male predominance, limb slim girdles, subfacial, multinodular, well circumscribed, uniform epithelioid, spindled cells and cord strands, peripheral condensation, abundant myxoid background. High grade is increased cellularity, solid growth. Definitive nugget: consistent NR4A3 rearrangements, UWSR1, NR4A3 most common. High recurrence and late metastasis potential.
That delayed metastasis really makes long-term follow-up absolutely critical for EMC patients.
Wow. Okay, let's talk about low-grade fibromyxoid sarcoma, LGFMS, sometimes called Evans tumor. You said it's notoriously deceptively bland-looking, yet carries significant metastatic potential. Tell us about its hallmarks.
LGFMS, yes. It's a true master of disguise. Looks incredibly bland under the microscope, but has significant potential for both late local recurrence and late distant metastasis. A major potential pitfall if you underestimate it. It's the same thing as what used to be called hyalinizing spindle cell tumor with giant rosettes. Clinically, affects young to middle-aged adults, 3rd, 5th decades typically. Equal gender distribution. Subset seen in kids too. Usually presents as a long-standing, painless, often large, deep-seated subfacial mass. Some can be subcutaneous or dermal. Predominantly extremities, thigh most common. Also trunk, head, neck, retroperitoneum.
Okay, young adults, deep mass, looks bland. What are the specific histological features?
Grossly, usually looks well circumscribed, but can infiltrate sometimes. Tan, firm, homogeneous cut surface. Usually no obvious necrosis or hemorrhage in the low-grade form. Histologically, the absolute characteristic feature and diagnostic nugget is the striking pattern of alternating fibrous and myxoid areas. Often has a whorled or swirling growth pattern within these areas. Think alternating fibrous and myxoid nodules. Within the myxoid areas, a key additional feature is the presence of arcades of thin-walled blood vessels. These delicate vessels form arches or loops. Sometimes they have perivascular hyalinization. The cells themselves are bland, short spindle cells, ovoid nuclei, fine chromatin,
Inconspicuous nucleoli, not much cytoplasm, arranged in those whorls. Nuclear atypia is rarely observed, reinforcing that deceptive blandness. Mitoses are usually scarce, necrosis rare. About one-third of cases also have giant rosettes. These are dense hyalinized collagen cores surrounded by palisaded epithelioid tumor cells. Another helpful morphologic nugget if you see them. The morphologic spectrum can include areas of higher cellularity or slightly more atypia, but the overall blandness usually dominates. Rarely, recurrent LGFMS can dedifferentiate into a high-grade round cell sarcoma. An occasional hybrid LGFMS sclerosing epithelioids fibrosarcoma exist, adding complexity.
Alternating fibrous myxoid, whorls, arcading vessels, bland cells, giant rosettes sometimes. What about IHC, molecular? Is there a specific marker?
IHC is crucial here. While it might occasionally be CD34 plus ESMA plus AIR or Desmond plus AIR, and over 60% are EMA positive. The definitive nugget is MUC4. MUC4 is a highly sensitive and specific immunohistochemical marker for LGFMS. This is an absolutely critical practice point. If you suspect LGFMS, you need to order MUC4.
MUC4, okay, that's huge. Molecular confirmation.
Yes, molecular genetics is also very distinctive and confirmatory.
Yeah.
LGFMS is characterized by specific translocations, T716, Q34P11, and T1116P11Pia. These fuse the FUS gene on 16PLM with either CF3L2 on 7Q34 or CREB3L1 on 11P11. The FUS CREB3L2 fusion is the most common, found in up to 95% of cases. Rare alternate fusions involving UWSR1 instead of FUS could occur. Okay, MUC4, IHC, and/or FUS phage, nail it down. How does it compare to mimics now that we have these tools?
Right, the high specificity of MUC4 and the translocation makes the differential much easier. Solitary fibrous tumor, SFT, alternating cellularity, patternless architecture. Hemangioparasitoma-like vessels, rarely Myxoid, lacks whorls, MUC4 negative but STAT6 positive. Soft tissue perineurioma. Can have whorls, collagenous myxoid stroma, lacks sharp fibrous myxoid zones and arcading vessels. Both can be EMA positive, but MUC4 is specific for LGFMS. Desmoid fibromatosis. Bland spindle cells and long fascicles, more infiltrative. Negative for MUC4, EMA. Nuclear gatenin positive in 70%. Low-grade MPNST, more infiltrative, perivascular cellularity. Longer spindle cells, tapering nuclei, some atypia mitoses. S100, GFEFPSOX10 positive in 40-50%. Myxofibrosarcoma. Older adults, often superficial, more uniformly myxoid, curvilinear vessels. Scattered pleomorphism. LGFMS is uniformly bland. MUC4 negative, complex karyotype. LGFMS has simple translocation.
MUC4 really helps cut through that differential. Prognosis, treatment. You mentioned late Mets again.
Yes, significant potential for local recurrence and late distant metastasis, even decades later. This is why long-term follow-up is absolutely critical. Don't let the low-grade name fool you about its long-term potential. The 5-year metastatic rate is low, 10%. But the long-term risk climbs to 30-40% after 10-20 years. Preferential metastasis sites, lungs and pleura, treatment, wide local excision is standard. And due to that delayed metastatic potential, long-term, potentially lifelong follow-up is required. Key practice points for LGFMS. Young adults. Deep, usually well circumscribed. Alternating fibrous myxoid areas, bland cytology, arcades of small blood vessels. No nuclear pleomorphism. MUC4 is sensitive and specific, confirmed with FUS gene rearrangement. Significant potential for late recurrence metastasis, especially lung. Long-term follow-up essential.
That potential for very late metastasis makes LGFMS a really critical diagnosis not to miss, despite its bland look. MUC4 is key. Okay, next, let's discuss myxo-inflammatory fibroblastic sarcoma, another low-grade sarcoma, formerly called acral, but now known to occur more broadly. What features, especially that inflammatory component, make this one such a notorious mimicker of reactive processes?
MIFS, yes, low-grade sarcoma. It used to be called acral MIFS, but yeah, not restricted to keratosites, those still most common there. Clinically affects adults, equal gender, median age, 5th, 6 decades. Vast majority arise in subcutaneous tissue of fingers, hands, ankles, feet, upper limb, lower limb. Less commonly, proximal extremities.
Okay, adults, hands, feet, subcutaneously often. What's the histology? What makes it inflammatory?
Pathologically, it's infiltrative with ill-defined margins. Stroma is variably myxoid and fibrous, or sometimes looks very inflammatory. Myxoid areas might have numerous pseudolipoblasts, similar to myxofibrosarcoma, which can add to confusion. A key diagnostic nugget is the presence, often sparsely, of distinctive large pleomorphic cells. They have vesicular nuclei, prominent inclusion-like nucleoli, not much cytoplasm. They often look strikingly like virally infected cells or even Reed-Sternberg cells. Finding these is crucial. There's usually a blander spindle cell component too. And these neoplastic cells are usually accompanied and often totally obscured by a variably prominent mixed inflammatory infiltrate. Lots of small lymphocytes, plasma cells, eosinophils. This inflammatory background is precisely why it's so often mistaken for just inflammation or a reactive process. You really have to hunt for those weird large cells amidst the inflammation and myxoid change. Some atypical features like hypercellularity or more mitosis don't predict metastasis but do correlate with higher recurrence risk.
Wow. Reed Sternberg-like cells and inflammation and myxoid stroma. That sounds tough. IHC help.
IHC is unfortunately not much help for diagnosis here. Those large neoplastic cells might stain for nonspecific markers like vimentin, CD68, CD34, but they're consistently negative for keratins S100 and critically Hodgkin lymphoma markers like CD30, PX5, CD15. Ruling out Hodgkin's is important given those cells. Molecular genetics, however, provides the definitive nugget. MIFS harbors a characteristic T1p22q24 translocation involving the TGFBR3 and MGEA5 genes in the majority of cases. Often also see amplification of chromosome 3p1112. Interestingly, that same T110 is also found in hemosiderotic fibrolipomatous tumor, suggesting they might be related entities or variants on a spectrum.
Okay, TB1, TGFBR3, MGEA5 is the key molecular finding. Differential diagnosis.
Differential diagnosis is challenging because it looks so inflammatory and reactive initially. You really need to spot those pleomorphic cells or the myxoid component. Differentiate from myxofibrosarcoma. MFS is typically superficial, affects older adults, often proximal. Has scattered pleomorphic cells too, but also those characteristic prominent curvilinear blood vessels, more extensive myxoid stroma usually, and generally lacks the dense mixed inflammation seen in MIFS. Differentiate from Hodgkin lymphoma. Positive for CD30, CD15, PAX5, MIFS is negative. And Hodgkin's doesn't typically present as a subcutaneous mass on the hands or feet.
Right, IHC and location help rule out Hodgkin's. Prognosis and treatment for MIFS.
Prognosis. It recurs frequently. Reported rates vary widely, maybe 20–70%. Getting clear margins can be tough due to its infiltrative nature. However, it very rarely metastasizes, mainly lymph nodes and lung if it does spread, but that's uncommon. Considered low grade. Treatment. Wide local excision with negative margins should be attempted to minimize recurrence. Key practice points. Adults, 5th, 6th decades, equal gender. Subcutaneous tissues of hands, feet typically. Variably myxoid fibrostroma, scattered Reed-Sternberg-like cells, prominent inflammatory infiltrate. Your definitive nugget is the consistent T110 translocation. Recurs frequently but rarely metastasizes.
That inflammatory component mixed with those bizarre cells truly makes it a chameleon. Great points. Finally, in this main section, let's briefly touch on a myxoid malignant peripheral nerve sheath tumor, MPNST. Not exclusively myxoid, but when it is, it definitely joins the differential.
All right, myxoid MPNST. It's a malignant nerve sheath tumor. Can arise sporadically with NF1 or after radiation. Most often deep soft tissues in adults. About 10% of all MPNSTs show some degree, focal or extensive, of myxoid stromal change. That's the variant we're considering here. Even within the myxoid areas, you should look for characteristic MPNST features. A fascicular growth pattern, bundles of cells, varying cellularity, tapering or wavy nuclei, and importantly, paravascular increased cellularity cells cuffing around blood vessels.
Okay, look for MPNST features even in myxoid areas. IHC, molecular.
IHC. S100, GFAP, or SOX10 are positive in 40–50% of cases, but often only focally positive, which can be a diagnostic challenge. You might miss it if you only sample a negative area. Molecularly, a key nugget is loss of nuclear H3K27E3 expression. This is seen in up to half of MPNSTs and over 90% of high-grade ones. It's a very useful surrogate marker for PRC2 dysfunction, often due to EAD or SUZ12 mutations. Helps confirm MPNST, especially high-grade. Differential diagnosis, as we touched on before. Differentiate from low-grade myxofibrosarcoma. MFS has curvilinear vessels, maybe less pleomorphism for cellularity, usually S100 positive. Myxoid neurofibroma, generally bland, diffuse S100. LGFMS, S100 negative, specific MUC4+, and FUS rearrangement. Myxoid MPNST, like conventional MPNST, is highly aggressive.
H3K27E3 loss is a key marker there. Good point. Okay, now to round out our deep dive, especially for you preparing for independent sign-out, we have a few other tumors. These don't always have prominent myxoid stroma, but when they do, they can certainly complicate the differential. This is where having that broad understanding really pays off, so you don't get caught by an unusual presentation.
Precisely. In these occasional myxoid variants, the histologic overlap can be significant. It often makes recognition really difficult unless you can find conventional histologic features elsewhere in the tumor, maybe in another block or biopsy piece, or you have to rely on specific ancillary studies to truly pin down the diagnosis. These are the curveballs that really test your comprehensive knowledge base.
Right, the zebras presenting atypically. What are some key ones to keep in mind?
Okay, first, myxoid nodular fasciitis. We think of nodular fasciitis as cellular, maybe tissue culture-like, but there's a myxoid variant, maybe 5% of cases. It's a benign fibroblastic, myofibroblastic thing, usually self-limited, often grows fast initially. Myxoid variant may be more common in kids. Head neck. Histology shows bland fibroblasts, myofibroblasts, and short fascicles with an abundant myxoid matrix, often with extravasated red blood cells. The molecular nugget now is the recurrent MYH9 USP6 gene fusion, T1722, helps confirm if needed. Next, myxoid dermatofibrosarcoma protuberans, DFSP, again a rare variant, maybe 5% of DFSP cases, clinically similar to conventional DFSP trunk. Histology involves dermis exupetus, monomorphic small spindle cells in myxoid matrix, really challenging because it lacks that classic tight store form pattern. Crucial to identify conventional DFSP areas if possible. That diffuse infiltration of subcutaneous fat, the honeycomb pattern, is a helpful clue even in myxoid areas. IHC, cells are CD34 positive like conventional DFSP, molecular. Harbors the recurrent T1722 CO1A1-PDGFB fusion. FESH for PDGFB rearrangement confirms it. Then myxoid solitary fibrous tumor, SFT.
Uncommon to see prominent myxoid change in SFT histology. Short neoplastic spindle cells may be reticular pattern in abundant myxoid matrix. Look for the classic patternless architecture and those mangioparasitoma-like Stackhorn vessels. Recognizing conventional SFT areas is key. IHC, 95%, CD34 positive. STAT6 nuclear staining is highly sensitive and specific. Molecular. STAT6 overexpression is due to the characteristic NB2 STAT6 fusion gene from an inversion on 12q13. That's the molecular nugget. Myxoid synovial sarcoma. Rare variant where myxoid stroma dominates, often just focally. Clinically similar to conventional synovial sarcoma. Young adults, extremities, often near joints. Histology. Neoplastic cells and prominent myxoid stroma may be a lacy reticular pattern. Crucial to identify conventional monophasic or biphasic synovial sarcoma areas if present. IHC, MMA positive, keratins positive, TLE1 positive, molecular. Phagina in ASH for SS18 rearrangement might be needed to confirm in tricky myxoid cases. Myxoid neurofibroma. Uncommon histologic variant, maybe 10% of neurofibromas. No increased late to NF1 specifically for the myxoid type. Histology. Small spindle cells, wavy tapering nuclei, in abundant myxoid matrix instead of the usual collagen. IHC. Majority S100 positive, some EME positive. Should see scattered neurofilament protein positive axons within it. Prognosis. Simple excision is curative, benign. Reticular and myxoid soft tissue perineuroma, uncommon benign lesion. About a third of perineuromas have some or mostly myxoid matrix, clinically. Equal gender. Subcutis or deep soft tissues. Reticular variant, often subcutaneous distal extremities. Histology, storiform, whorled, or lamellar patterns. Bland ovoid to spindle cells. Reticular variant has this net-like pattern of elongated spindle cells with thin bipolar processes, invariably myxoid stroma, IHC. MMA positive often highlights those processes, but might be focal. Claudin-1 positive in a subset. Prognosis rarely recur, benign. And finally, a microcystic reticular, myxoid schwannoma. A usual variant likes visceral locations, especially GI tract and older adults. Histology, spindle cells, elongated tapering nuclei. Reticular growth pattern often forming small cystic spaces. Can look myxoid, IHC, diffusely and strongly S100 positive. Prognosis, excision curative. No recurrence is reported despite sometimes looking infiltrative locally. Benign.
Okay, that's a great rapid-fire overview of those less common myxoid presentations. Really important to keep those possibilities in mind. So after this really intense and detailed journey through the world of myxoid tumors, what's the bottom line? What does this all mean for you, the new surgical pathologist, standing at that microscope with a challenging myxoid case, aiming for that confident, independent sign-out?
Yeah, it means that navigating this world of myxoid soft tissue tumors is, well, it's truly a masterclass in surgical pathology. It really demands your sharpest observational skills and integration of all the data. You've seen how absolutely crucial it is to move beyond just saying, oh, it's myxoid. You have to dig into those specifics, sometimes subtle details, the depth of the lesion, the definitive presence or absence of nuclear pleomorphism, and those highly distinctive vascular patterns, the crow's feet or the arcades or the curvilinear ones. These morphological clues are your first line of defense. They have to guide your initial thinking and your differential.
And then the ancillary studies, the reliance on IHC markers like MUC4 for LGFMS or the consistent S100 for nerve sheath tumors, and particularly the molecular genetics, with those incredibly specific gene translocations and mutations, gene AS for intramuscular myxoma, FUS DBIT3 for myxoid lipo, NR4A3 for EMC, FUS for LGFMS. That really seems to be the key to unlocking these diagnoses, doesn't it? It's about knowing when to order them and knowing what specific molecular fingerprint you're looking for to definitively distinguish between entities that look almost identical otherwise. That seems crucial for sign-out confidence.
Exactly. You absolutely nailed it. Your meticulous approach to morphology, really careful examination, coupled with a keen understanding of the immunophenotypic patterns and increasingly those molecular profiles we've discussed. That combination will be your most powerful toolkit for confident sign-out. And always remember why it matters so much. Distinguishing a benign, self-limited thing from a sarcoma with high metastatic potential has absolutely profound implications for your patients. It dictates surgery, radiation, chemo, follow-up, everything. Your accurate diagnosis directly impacts their lives.
It really does. So as you, our listener, move forward in your practice armed with these insights, maybe consider this. Beyond just making the diagnosis today, how might a deeper understanding of the specific molecular drivers of each of these myxoid tumors, even the ones we currently just treat with surgery, how might that inform future therapeutic strategies in ways maybe we're only just beginning to imagine? What further insights will genetics unlock for precision medicine in this really complex and often confounding field of pathology? Something to think about. And that concludes our deep dive into the fascinating and, yes, at times, quite perplexing world of myxoid soft tissue tumors. We really hope this exploration has equipped you with the critical insights, those key nuggets, and the confidence you need for your independent sign-out journey.
Yes, thank you for joining us on this really in-depth journey. Stay curious. Keep looking closely at those nuanced details under the microscope. And always remember to connect the dots: morphology, immunohistochemistry, and molecular findings. That's where the true diagnostic power lies. And honestly, that's where you'll find the most satisfaction in your practice, solving these challenging cases.